Hi, welcome to PH Insights presented by the Pulmonary Hypertension Association. Join us as we delve into patient stories, healthcare updates, and the latest insights on pulmonary hypertension. Thank you for joining us today. My name is Angela, and we're going to take a closer look into pulmonary hypertension and interstitial lung disease. Joining me today is Dr. Abu. Dr. Abu, thank you for being here. I'll give you a moment to introduce yourself.
Thank you, Angela, for having me here with you on the podcast. My name is Dr. Abu Homoud. I specialize in pulmonary and critical care. I did my residency here in New Jersey at Jersey Shore University Medical Center, and then went on for training and fellowship in Chicago, Cook County Hospital. And now, since I came back, we noticed that this area had deficit in centers that can treat pulmonary hypertension. So we tried to establish a program and now involved in academic and teaching at Jersey Shore University Medical Center as a associate PD and Pulmonary and Critical Care Fellowship. And after we opened the Pulmonary Hypertension Center, I'm the director of that center.
Again, thank you for joining us today. Later on the next episode, Jeff Spiewak will join us to share a little bit more about his journey with PH-ILD or interstitial lung disease. I wanted to kind of share a little bit of his story before we get started. And that way we can kind of take a closer look at what ILD means for PH patient and vice versa. If you allow me for a moment, let's hear a little bit from Jeff before we get started.
Hi, my name is Jeff Spiewak, and I'm from Tinton Falls, New Jersey. I was diagnosed with pulmonary hypertension and interstitial lung disease in January of 23. My journey in hindsight, I believe, began back in January of 2017. We had a snowstorm here, and I was shoveling my driveway. And right from the start, I could only shovel a couple of times, a couple of shovel loads, so to speak, before I had to sit down and take a break. Mind you, when I was growing up, I was one to kind of avoid the doctor. I wasn't making regular doctor appointments. I was relatively in good health, maybe a couple of colds every year, but nothing major, nothing that I really felt that I needed to go to the doctor. Although looking in hindsight, that probably wasn't the smartest thing to do. Between 2018 and 2022, I was finally making regular doctor visits to my general doctor. A couple times I had a nuclear stress test, an EKG, echocardiogram, and a pulmonary function test, and mostly to deal with my heart. The tests seemed to come out normal. Nothing was wrong with my heart, although the doctor did diagnose me with high blood pressure. So he had put me on high blood pressure medicine at that point. On Thanksgiving Day of 2022, the next day actually, I felt the pressure in my chest. Almost felt like I had maybe eaten too much the day before, but I knew that I hadn't. So I figured this was the time to finally get to the doctor and see what was going on. So bring us to 2023, made my regular visits with my regular doctor. He again did an echo, EKG, I think a stress test, and things were still coming out normal with my heart. But I did mention to him that I was still having the feelings of exhaustion on exertion. So he suggested at that time that I see a cardiologist, which I then went ahead, made an appointment in the summer of 2023, visited a cardiologist. He did a series of tests, series of blood work, and also changed my high blood pressure medicine. After a number of tests, he diagnosed me with pulmonary hypertension. So at that point, we had a diagnosis, but again, I had mentioned to him that I was still feeling these feelings of exhaustion on exertion, shortness of breath. I was getting tired. So the cardiologist at that point suggested that I go to see a pulmonologist, which I did towards the end of 2023. I went to a pulmonologist. Pulmonologist did a number of different tests. After the tests and blood work, he had referred me to the pulmonary hypertension group at Jersey Shore Medical Center. And they continue with a few tests, including a right heart cath. And at that point, after all the tests and the blood work, they diagnosed me with pulmonary hypertension, interstitial lung disease. And from that point on, from January 23, I've been under the care of a terrific group of physicians at Jersey Shore Medical Center.
So we just heard from Jeff and we learned a little bit more about his diagnosis. We'll hear from him later. But can you, Dr. Abu, kind of explain a little further the connection between PH and ILD? We see Jeff was diagnosed with pulmonary hypertension first before his ILD diagnosis. Can you kind of give us an overview of PH real quickly?
So it's a good start to tell the audience about what's pH. So pulmonary hypertension, it means that the pressures inside your lung are higher and than usual and elevated compared to normal pulmonary pressures. It's like systemic hypertension where your blood pressure is elevated. It's the same, but for the pulmonary circulation. And in terms of the ILD, so interstitial lung disease is disease that leads to lung having some scarring in it, and it progresses most of the times, and that scarring makes the lung stiffer and very tough to expand, which makes it look like on a pulmonary function test that it's smaller because it can't expand. And PH and ILD can coexist in about 30% of the patients, and usually ILD is diagnosed prior to PH, the opposite way of Jeff. And that leads to the delay in diagnosis of pulmonary hypertension because ILD and PH have similar symptoms, which includes the shortness of breath that Jeff was explaining, inability to do usual work, and an ability to take normal breath and do and enjoy the normal activities.
So with ILD, you said that typically ILD is diagnosed first. What are some of the potential causes for ILD to be diagnosed first?
So when, as Jeff was mentioning, that when you face a patient where they're complaining to you and explaining to you that they can't do what they're able to do in the past. You do
Mhm.
all the cardiac workup and you do pulmonary workup, and in part of the pulmonary workup where you do the pulmonary function test, where you have your lung capacity reduced, if the interstitial lung disease is really in early stages, the lung
Mhm.
capacity will be normal on a pulmonary function test. But if patients have persistent symptoms, a lot of times we do a CAT scan, and ILD is mainly diagnosed on CAT scan, where you can see the scarring and the beginning of stiffening of the lung on a CAT scan.
So are there also any contributing diseases or factors that would lead to a PH-ILD diagnosis? How are we connecting PH-ILD?
So, interstitial lung disease can be caused by multiple diseases and also environmental exposures, such as coal workers, miners, and people that work with asbestos, and a lot of jobs where you have welding, you get exposed to a lot of inhalation material. It can lead to fibrosis of your lung, but also genetic factors play a role where you can have autoimmune diseases like scleroderma, lupus, rheumatoid arthritis that can lead to scarring of the lung. And how interstitial lung disease and pulmonary hypertension connected? Well, in case of the environmental exposure, after you start getting scarring of the lung, the same process that leads to scarring of the lung can lead, like the same way it hardens the lung, it can lead to hardening of the pulmonary artery itself, leading to increased pressure because they're stiffer right now. And on the other hand, if you look at the genetic component where you have autoimmune diseases, the autoimmune disease itself, without causing scarring in the lung, can lead also to pulmonary hypertension by affecting the pulmonary artery and the smaller blood vessels, leading to stiffening and elevation in the pressure.
So if I am an ILD patient, I am still having some difficulty how would I know to even ask for or determine if I also have pulmonary hypertension? Is there a natural progression for diagnosing PH in an ILD patient? Like, will a pulmonologist automatically test or your initial doctor automatically test to see if you have PH?
Well, that's a very good question, Angela, because as I mentioned before, PH and ILD have very similar symptoms, which
Mhm,
include shortness of breath, sometimes the drop in oxygenation, inability to do the similar stuff that you're able to do usually. As a pulmonologist, we use like a bunch of tools. Like we don't depend only on symptoms, only on numbers, only
mhm,
on CAT scan to diagnose PH with ILD. You have to look at like shortness of breath out of proportion for how much scarring is in the lung.
mhm,
Or on the lung function test, you see decrease in oxygen exchange that is out of proportion again to the other deficit in the lung function test, like the lung capacity and how much air you can exhale out in 1 second. If those they don't match, you have to do a screening echo.
mhm.
And again, a lot of times the echo does not catch the elevated pressure in the lung in about 20% of the cases. So if the suspicion remain high, then you have to go on for the right heart catheterization. Again, if the symptoms and the oxygenation is out of proportion to the findings that we see in the patient.
So once it is discovered, if, patient is diagnosed similar to Jeff's experience with PH-ILD, what are some treatment approaches for this, or what are some options that are available?
So pulmonary hypertension is a growing field right now. It wasn't very popular until like in the recent years where they shed more light on pulmonary hypertension treatment
Mhm,
and they start doing some more clinical trials about it. For us, pH specifically associated with ILD, in the past, the treatment was to just provide supplemental oxygen, maintain the oxygenation above 90%, because if if you deprive the lung from oxygen, the natural response will be for the pulmonary vessels to constrict, which leads to elevation in the pressure. But
mhm.
providing oxygen will lead to them to relax and reduce the pressure. Other treatments are pulmonary rehabilitation to increase their exercise capacity, ability to breathe better, and strengthening the respiratory muscle. And then lastly, we look at medications. Most of the treatments initially used to be where we use the data from the pulmonary arterial hypertension, which is the idiopathic and hereditary group where you don't have the lung affected. And then we try to use it for ILD too. Some of the trials looked at sildenafil, which showed benefits. So that's why one of the treatments is sildenafil that we use with the patient. And other treatment where we have the most recent trial, which made the FDA approve the first medication for PH-ILD, which is Tyvaso. It's a treprostinil, which is a prostacyclin inhaler, where you use it to dilate the pulmonary artery. Now, ongoing research about more medications, which include now also the FDA approved a new drug called
Mm,
sotatercept, which actually tries to reverse the process of the pulmonary artery hardening and becoming thicker. It
mhm.
induces the pulmonary artery to go back to normal size and be more relaxed. Other actually focuses now on the new studies for PH-ILD. Some studies are trying to focus on the prevention of ILD from progressing because again, PH and ILD have similar mechanism of evolving. The
Mhm,
same way the lung harden, the pulmonary artery will harden. So they're trying to focus on medications to stop this process, to stop the pulmonary arteries from hardening, plus the lung from hardening. So they used one of the pulmonary artery drugs to see if it actually stops the progression of both the ILD and the pulmonary hypertension. It showed some promising in preventing the progression of ILD, but really did not affect the pulmonary arteries much in the early stages. Other drugs has been studied to reduce the progression of ILD, and now there are new drugs going trials to add on top of antifibrotic medications that also prevents the pulmonary artery vessels from proliferating and increasing in size, leading to pulmonary hypertension.
So you mentioned these drugs. You mentioned specifically pulling out one is an inhaler. Are all these inhaled therapies, or how are these actually? How are the patient actually receiving some of the treatments that you mentioned here?
So sildenafil, which is a PDE drug, is orally taken. So it's
Mhm.
pills where you can take. You have the inhaled medications like the Tyvaso, and then you have injection, such as Luspatercept, which is every 3 weeks you get an injection of the drug. So you have all sort of on a spectrum medications that patient can take and available for patients.
And I'm assuming you titrate through which option works best for the patient.
So our treatment in pulmonary hypertension is always patient tailored. Whatever the patient is able to tolerate, we adjust the medications based on their tolerance, because a lot of these medications have side effects, and we
Mhm.
understand that. And our bodies behave differently and respond differently to different types of medication. Some of us will have side effects for this medication more than others, and that's why the side effect profile ranges between rare side effects to very common side effects. And even if patient experience side effects, we try to work with the patients
Mhm.
to try to pre-medicate, try to prevent these side effects before they happen, or if they're not very severe, to treat them after they happen, such as if they have headache, we give you some Tylenol, or pre-medicate with Tylenol and Advil to prevent these headaches from happening.
Should a patient share all of their side effects through? I've had conversations with some members of the PH community, and they're like, well, I just want to get through the drug. I'm not going to, share my side effects because I don't want to stop it if it's going to make me feel better long term. So, do you recommend patients sharing every side effect they have with their medical team?
Yes, absolutely. They have to share every single side effect, even if it's minor,
Mhm.
but if we have it on the radar, in case that side effect starts becoming more of a problem, we can provide treatment, again, supplementary treatment, prevent it from happening. We
Mhm.
have we have specialty pharmacies that work with us and with the patient to actually try to reduce any side effect and prevent it from happening to begin with. So I encourage all the patients to actually report side effects, no matter how minor they are, just to
Mhm.
keep the providers like within the loop of and keep an eye on all of these side effects, because as some of these medications are titratable. So we have to increase the dose to reach a
Mhm.
target dose, like the inhaled Tyvaso. You keep going up on the drug. So if you experience the side effect, even if it's minor with a lower dose, it might be more prominent as we go up on the doses. So having it on the radar helps us prevent this side effect from becoming a problem and improve patient compliance with the drugs.
You also mentioned pulmonary rehab. Now, if someone hears that, they may think, oh, I can just go exercise on my own. What is the difference between just going to the gym and a pulmonary rehab?
So we always encourage patients also to exercise by themselves,
Mm.
because the pulmonary rehab is typically 2 to 3 sessions a week. And we encourage the patient to keep up with the exercises on their own. But the main difference is that pulmonary rehab is actually ran by respiratory therapists, a trained medical professionals that will focus on each, like, how you improve your respiratory muscle and becoming more efficient in helping you breathe. And they also adjust your exercise and exercise plan based on your progression, based on your oxygenation, because they keep
Mhm.
monitoring your vital signs throughout the exercise. And so, for example, if you have higher tolerance, they can progress faster and be more aggressive with you compared to patients who have more severe disease and have lower oxygenation compared to other patients. So, pulmonary rehab really is directed by medical professionals and focuses mainly on the respiratory muscles and the ability to do more. compared to regular gym exercises where it focuses in general about all of your muscles, like leg muscles, arm muscles, instead of like the main focus being improving your exercise capacity.
You also mentioned oxygen therapy or use of oxygen. Can you explain that a little bit, please?
Oxygen therapy. We at the Pulmonary Hypertension Center, every single patient with pulmonary hypertension needs to get a test that is called 6-minute walk test, where we walk you for 6 minutes at your own pace to see how far can you go, one, and two, to see if your oxygenation drops. So we have a device called the pulse oximetry put on your finger where it measures the amount of oxygen in your blood or the percentage of your blood that is oxygenated. Normally, in normal individuals, your expected oxygenation percentage is 95% and above. But when you start having pulmonary diseases like ILD, COPD, or pulmonary vascular diseases like PA, this percentage start dropping because the lung becomes less efficient in extracting oxygen from our normal room air. So our acceptable level for patients with lung conditions and pulmonary vascular conditions is 90% and above. Again, because below that level, the lungs start becoming angry and the pulmonary vessels start becoming smaller and they constrict to protect you. That's a protection mechanism for our lung. Now, in terms of when to prescribe it, we usually are able to prescribe it only if your oxygen level reaches 88% and below. We want to try to maintain it as close as possible to 90% and above during exercise, rest, and sleep. So basically 24 hours. So what we do to supplement oxygen, there are devices called oxygen concentrators that we
Mm-hmm.
prescribe for the patient. It's a small device with a battery that can last 8 to 12 hours that concentrates the oxygen in the normal air and provides it for the patient. So they can be mobile and they carry it around in like a small bag to help maintain their oxygen. And at home, there are stationary concentrators that they can use at night that you plug into the wall. They're just run on your regular outlet electricity.
And you're able to monitor this, or they share information to you to make sure they're staying at the correct percentage?
So mostly we depend on, after we prescribe the oxygen, we depend on
Mhm.
what the patient shares with us. And then again, every visit, we recheck the patients and we do the 6-minute walk test to make sure we do it on room air. And if they are
Mhm.
on oxygen, we do it with the oxygen to ensure the adequacy of the amount of oxygen we're providing them. For nighttime, we do what we call night pulse ox, where
Mhm.
we the same pulse ox that we use in the clinic, but the patient wears at night and record the whole night time and the level of oxygen and like for how long the oxygen stayed down and for what time period of time of the night. And if we suspect that the oxygen that we're giving them is not enough at night, which we can predict from the exercise, so if it's not adequate on exercise, usually at night you should start suspecting that it's not adequate at night. So we also um, repeat the test with them on oxygen.
So, lastly, before we end today, I would love for you to just share the future of research and information you may have for PH-ILD patients. What would you want them to take from this call?
So for all our patients with ILD, the message I would give them is that we have a lot of options these days for preventing the progression of ILD, for treatment of pulmonary hypertension associated with ILD, and again, pulmonary hypertension field is really growing, and we're living in an exciting time where new medications are coming up, and some of them are being approved right now, and we're just waiting for the FDA to release them to the market so we can prescribe them for patients. What really the most important message here is not to lose hope. Work with your
Mhm.
providers in terms of medications, and even if you do have some side effects, please share with your providers because we have medications to make these side effects go away or make them tolerable, as medications are important to prevent the progression. In terms of if they don't follow with a pulmonary hypertension center, I would ask them if they can ask their provider about screening them for pulmonary hypertension. I think this is the best way to try to detect it as early as possible because some of the symptoms are all similar between PH and ILD, and screening is the key for early detection. Now, there's also studies about looking at how accurate are we in detecting pulmonary hypertension in patients with ILD, and actually our center, Jersey Shore, is gonna be part of the hostel participating in such a study to see how good clinicians are in detecting pulmonary hypertension. So ask about screening tools from your providers and always be hopeful.
Thank you, Dr. Abu. That was very informative. I really appreciate it. I would love to leave on that note that screening is the key for early detection diagnosis. Again, thank you so much. And thank you to Jersey Shore University Medical Center for lending your expertise to us. We really, really appreciate it. And thank you for listening to PH Insight presented by the Pulmonary Hypertension Association. Remember to subscribe and to join us every second and fourth Wednesday of the month for more valuable insight. Bye, y'all. Thank you for listening to this episode of PH Insights. We'd like to take a moment to thank our sponsors for their support of the PHA Connects program, which brings you the PH Insights podcast. Sponsors do not participate in the development of and do not endorse content of programming. For a list of our sponsors for 2024, please visit our website at phassociation.org/aboutph/sponsors. Thank you for listening.